Bismillahirrahmanirrahim. We will complete with the respiratory tract problem in children, and we start with this case scenario for other respiratory tract problem. A 5 years old male presented to your office with that productive increasing at night. So the patient has chronic cough increasing at night, worse with exercise and with upper respiratory tract infection. His growth is normal. Chest X-ray findings are normal except for mild hyperinflation. So, for summary for this case, we get recurrent chest problem, worse with exercise and infection, and there are no fever, X-ray showing sign of hyperinflation. So from common problem, childhood asthma, because the problem is recurrent, there are cough, dyspnea, wheeze, and sign of hyperinflation. So what our learning objective from this lecture? When to diagnose asthma and what are their trigger factors, and should identify common presentation of asthmatic child, relevant finding of pulmonary function test and other diagnostic tools, emergency management of acute asthmatic exacerbation and long-term asthma control, family counseling about the asthma preventive measures, controller medications and device. How can we define asthma? Asthma is chronic inflammatory disorder of the lung airways, result in episodic airflow obstruction, presented as recurrent wheeze, cough, chest tightness, and dyspnea. The airway obstruction is widespread but variable and generally reversible either spontaneously or with treatment. Previously they defined asthma as hypersensitivity disorder. The last years they changed to chronic inflammation. So from this definition, the attack is episodic. It's not a continuous. And it's widespread bilateral chest involvements, generalized chest problem. And it's reversible either with treatment or spontaneously. Epidemiology of asthma. There is what's called asthma pattern in children. There are main two types of asthma in children. First, what's called transient non-atopic wheezing. This is common in early preschool years. Recurrent cough, wheeze, primarily triggered by common respiratory tract infection, usually resolved during the preschool and lower school years, without increasing risk for asthma in later life. So in this type of asthma, it's transient and usually precipitated by flu-like or upper respiratory tract infection, and there are negative family history of atopia, and the baby have no allergic disorder, and it's resolved over progressive years and is not developed to adult. Another type of asthma is more common is persistent atopy associated asthma. This began early preschool years, associated with atopy in early preschool years. So the baby may have eczema, allergic rhinitis, conjunctivitis, history of allergic disorder. Clinically, patient could be atopic dermatitis in infancy and allergic rhinitis, food allergy he may get. Biologically, we may find early inhalant allergen sensitization, increased serum immunoglobulin E, and increased blood eosinophilia. So this is the different point from the first class. There are high risk for persistence into later childhood and adulthood. Continue with persistent atopy-associated asthma. There could be with lung function abnormality. Those with onset before 3 years of age acquired reduced airflow by school age. Those with later onset of symptoms or with later onset of allergic sensitization are less likely to experience airflow limitation in childhood. So, baby that acquired disease more earlier, more liable to affect lung function. Asthma with reduced or declining lung function in children. Asthma with progressive increasing in airflow limitation associated with hyperinflation in childhood and male genders. Etiology. What could be the etiology of asthma? There are no definitive etiology, but our research implications are interplay between genetic and environmental factors. A genetic cause has been linked with a gene locus containing pro-allergic, pro-inflammatory genes on interleukin, what's called interleukin 4 gene cluster on chromosome 5. They found it. There are some link with this gene and make the genetic cause of asthma. Environmental factor as viral infection of the respiratory tract and allergic exposure in sensitized individual to irritant. They found that 30% of acute bronchiolitis may get recurrent with in the future. What are the risk factors for the child or infant to have persistent with or persistent asthma? Parental asthma. Found out if both parents have asthma, 50% of children may get asthma. If only one parent, 25%. Allergy. History of atopic dermatitis, eczema, allergic rhinitis, food allergy. Inhalant allergen sensitization. Food allergy sensitization. All can be spot for persistent wheeze. Severe lower respiratory tract infection, pneumonia, or bronchiolitis required hospitalization. Other wheezing apart from cold, male gender, and low birth weight. So this factor associated with persistent wheeze for patient with cold. Other environmental tobacco smoke exposure, so it's called passive smoking, also a risk factor. Reduced lung function at birth. Baby with reduced lung function at birth may get persistent wheeze. What could be the pathogenesis for us? What happened in the airways? This can be summarized by there are airway obstruction is a result of bronchoconstriction of the smooth muscle of the respiratory airways. Increase mucus production and edema formations due to inflammatory problems. Airway inflammations and basement membrane thickening. They are what's called wax and waning phenomenon. They are thickening of the basement membrane of the airways and leading to the narrowing. In addition to the secretion and edema formation, all this lead to the airway obstruction. There are two distinct phases and airway obstruction after exposure to the allergen. The patient is exposed to the allergen, he may get early phase and within 15 to 30 minutes after allergen exposure, baby have dyspnea cough, and this can resolve with a bronchodilator, inhalation or nebulizer. Late phase within 4 to 12 hours after allergen exposure and mainly due to inflammatory problems, and can be managed by corticosteroid to control this phase. So we need bronchodilator and steroid, both of them together in asthmatic child. What are the clinical manifestations? Asthmatic patient. The main problem is chronic symptom, RIK aspect of asthma. Patient has recurrent attacks of cough, wheeze, chest tightness. So this is the main problem. Intermittent dry coughing and or expiratory wheeze are the most common chronic symptom of asthma. Chest tightness and breathlessness reported by older children sometimes. Other symptoms of decreased physical activity and general fatigue, possibility due to sleep disturbance. Respiratory symptoms are characteristic worsening at night. So mainly the symptom is worsening at night because the half-life of drug is decreased. There may be increased risk of reflux at night, increased parasympathetic at sleeping, and this leads to the bronchoconstriction. So main symptoms: chronic cough, precipitated by cold, flu, exercise, some medications. They are found that 90% of acute asthma exacerbation they precipitate by upper respiratory tract infection in children. Symptoms typically provoked by numerous events or exposure. Common viral infection, respiratory tracts, 90% of cases. Allergen sensitization, animal dandruff, indoor allergen, mites, cockles, molds, seasonal allergen, pollens, tree-associated weeds, seasonal mold, environmental smoke, other factors, air pollution, ozone, dioxide, dust, mycotoxin, wood or coal-bearing smoke, strong or noxious odors or fumes, perfumes, hair spray, all this can lead to the airway irritation. Occupation exposure, it's called occupational asthma. Those working in some areas that lead to the exposure to the irritant. Cold, dry air, exercise, crying, laughing, and hyperventilation. There are what's called comorbid condition. This is very important and worsening the condition in asthmatic child. It's called rhinitis, sinusitis, and gastroesophageal reflux. This is a comorbid condition for asthmatic child. What we find on examination of the child? On chest examination may be normal when the baby have no attack of exacerbation. So it could be normal examination. Expiratory high pitch wheeze is heard and sometimes audible without stethoscope. Identified comorbid conditions. During exacerbation, there are prolonged expiratory phase and wheeze. With time, with worsening of the condition, the patient may have segmental crackles or rales due to atelectasis or atelectasis due to mucus plug that block the airways. In severe exacerbation, there is a sign of respiratory distress as nasal flarynx, brasternal notch, and intercostal subcostal recessions, use of axillary muscles, and expiratory wheeze. So, with the initiation, there are expiratory wheeze, then become expiratory and expiratory wheeze, then we add crackles in the more severe, and more severe cases, the baby may get silent chest, what's called poor air entry, and it's a sign of status asthmatic. History and physical examination. The diagnosis we need to history and physical examination. We need pulmonary function test, history of recurrent wheeze and cough, history of allergen, and on examination by examination of bronchi, by auscultation of chest, we suppose this patient has asthma. We do pulmonary function test. It's helpful the diagnosis of asthma first, assessment of asthma, severity second, and efficacy of our treatment. So 3 jobs for pulmonary function test. We can use spirometry. This measure airflow and lung volume during forced expiratory maneuvers. Forced expiratory volume in the first second is decreased, and forced expiratory volume on forced vital capacity, which is less than 0.8, is consistent with improvement consisting with asthma. Improvement in forced expiratory volume after inhalation of beta agonist more than 12% also consists with asthma. And this test is visible in patients after 6 years of age. So we cannot do this spirometry in patients lower than 6 years of age because he is not able to do proper full expiration and inspiration. This is diagram shown. And the first one is normal baby and the second one is case. So in this diagram we found the normal child and asthmatic child. In the initial first second we found a restriction in the second patient which is asthmatic, whereas the total or the end is equal and forced vital capacity is equal both of them, but there is decrease in the first second. So when we divide the first expiratory volume in the first second and forced vital capacity, it's less than 0.8 in asthmatic child. You can do some chemical test to diagnose asthma. Inhalation of histamine or methacholine. This is the provocation test, but it is a risky test to do and should be tested in intensive care unit or the hospital because might exacerbate problem or distress. Also, we can do exercise test and a big expiratory flowmetry. This is monitoring this test done by assessment of severity of big expiratory flow morning to evening variation. Greater if the big expiratory flowmetry, the variation between morning to the evening more than 20% is consistent with asthma. So this test can be done at home. We learn the patient to do big expiratory flow instrument. He take 3 readings at morning and 3 readings at evening for at least 3 weeks and comparison. And by this test, if the change more than 20%, this goes with a diagnosis of asthma. Also, we can do a provocation test by exercise. The first expiratory and first second typically decrease during and after exercise by more than 15%. This is diagram show for big flow meters. There are 3 zones. We get green zone, yellow zone, and red zone. In a patient with green zone, the value above 80 is normal person. From 50 to 80 it's yellow zone, this is intermediate zone. And the red zone is risky zone, that the patient has less than 50% of reductive, and this is mean the patient is worsening. So when take the patient reading and it's at the red zone, mean the patient need much treatment to improve his condition. And this 2 readings, the morning and evening reading, and so the variation in between them. Look to the second or down pictures that the patient has decreased his respiratory function and he now receiving steroid, he start to improving his condition. So the patient take 3 times big spirometers and take the highest result at morning and do 3 times and take high result at evening for 3 weeks and to see the variation in between and how percentage from predictive. If the baby is 80 and above is normal, 50 to 80 is in between and less than 50 is worsening and need further management. So this diagram will show what main abnormal pulmonary function tests in asthmatic child. First, the forced expiratory volume on first expiratory vital capacity less than 0.8. Bronchodilator response when given the baby nebulizer. He will improve by more than 12%. With exercise test, he will worsening more than 15% in forced expiratory volume. And daily peak flow meters, morning to evening variation more than 20%. This is 4 criteria abnormal pulmonary function in asthmatic child. What other tests? We do radiology. Maybe normal. There may be sign of hyperinflated chest. Sometimes detection of complication as atelectasis, pneumothorax, or emphysema. Or for other diagnoses, maybe other congenital heart, pneumonia, or other problems other than asthma. So, it's not routinely to do X-ray in every asthmatic patient. Usually we do if the patient had first attack, you suspect complication, and or you suspect other diagnosis. So not routinely X-ray in any patient. This chest X-ray in asthmatic patient show there are signs of hyperinflation of the chest. Treatment. Our goals of childhood asthma treatment: first, try to maintain normal physical activity, prevent chronic asthma symptoms, maintain normal lung function, and prevent severe asthma, experience little to no adverse effect of medications, and prevent sleep disturbance. So this is our job. How can we this job can be achieved? This is by regular assessment and monitoring, by control of factors that contribute for asthma severity, by elimination or reduce environmental exposure, dust, mite, or tobacco smoke, treatment of comorbid conditions as rhinitis, SANS, and gastroesophageal reflux. Also, patient educations and asthma pharmacotherapy. So, monitoring, elimination of risk factor, patient educations, and asthma pharmacotherapy. Before you start asthma medication, you should classify the patient according to the severity. And this is required some parameters. Frequency of daytime symptoms, frequency of nighttime symptoms, degree of airflow obstruction by spirometry, and peak flow variability. Peak expiratory flow variability. This diagram or table shows there are 4 types of asthma. There is what's called intermittent, mild intermittent, mild persistent asthma, moderate persistent, and severe persistence. And these parameters show the severity. In daytime, patient with mild intermittent is less than 2 days per week, more than 2 days per a week at night, daily, in moderate persistent and in severe persistent, daily throughout the day, the attacks of exacerbation. Night times, patient with mild persistent, you get less than 2 times per month, 3 to 4 nights per month in mild persistent, more than 1 per week, but not a daily or nightly attacks for moderate persistent, and often 7 times per week or nightly attacks in patients with severe asthma. In short-acting beta agonist, Can use less than 2 days per week in patient with mild intermittent, more than 2 days, not daily in patient with mild and intermittent, daily use of bronchodilator in patient with moderate persist, and several times per day in severe. Exercise limitation, there are no limitation in mild intermittent, minor limitation in moderate, mild persistent, some limitations, and severe limitation in severe types. And lung function abnormality is normal in the mild intermittent, less than 80 of reductive in mild persistent, 60 to 80% of reductive in moderate persistent, and less than 60% of reductive. And lastly, the percent of forced expiratory volume and forced vital capacity, more than 85% in mild intermittent asthma, more than 80% in mild persistent, and 75 to 80 in moderate persistent, and less than 75% in severe persistent. So this diagram will categorize the grade of asthma according to the finding in this table. There are two types of medication, what's called quick relief medications. This treatment of acute attack of asthma. First, we get inhaled short-acting beta agonist as albuterol, salbutamol, and terbutaline. Inhaled anticholinergic agent as pratronia bromide, prednisolone or methylprednisolone. These drugs can be used in severe exacerbation or acute exacerbation to hasten recovery, and we get oral prednisolone, hydrocortisone, or methylprednisolone. Long-term control medication. This is used for long-term or persistent asthma as control medication. We get 5 groups. First, non-steroidal anti-inflammatory agent, chromalin and nidochromium, inhaled glucocorticoid. This is the backbone of asthma treatment. This is very important, as beclomethasone, budesonide, and triamcinolone, largely used in treatment of asthma. The side effects of these medications include oral candidiasis or thrush. لذلك we ask the patient to gargle with waters. Dysphonia due to vocal cord affection, hoarse voice, and growth. Other groups: sustained release theophylline, long-acting inhaled beta agonists as formoterol and salmeterol, leukotriene modified agent as 2 groups. Leukotriene sensitized inhibitor as xylitol, is not used below 12 years, and leukotriene receptor antagonist, example zavrelakast and montelukast, is widely used as chewable tablet, 4 mg, 5 mg, 10 mg at night, single for 4 months, cause prophylaxis. This block exercise, aspirin, and allergen-induced bronchoconstriction. So leukotriene is important. Long-term medications regarding the asthma types. In mild intermittent asthma, no daily medication is needed. In mild persistent, only once daily anti-inflammatory agent. Either we give him low-dose inhaled steroid or leukotriene modified agent or slow-release theophylline, whatever. So only one anti-inflammatory medication or long-term medications. In moderate persistent, either we give him once daily medium dose inhaled steroid or low dose inhaled steroid plus what anti-inflammatory agent, theophylline, low dose inhaled steroid with long-acting beta agonist. In severe persistent, we can use daily medication and high dose inhaled steroid plus long-acting beta agonist, other leukotriene, so many drugs can be used, even sometimes systemic steroid as prednisolone tablet for those patients. This is picture for spacer device. This is used for baby that below 5 years unable to use inhaler, can use in metered-dose inhaler with the assistance of spacer, and the baby can puff during this space and inhale for 1 minute to take medication, special for steroid, inhaled steroid. Acute exacerbation management. In acute exacerbation, the patient comes with dyspnea, distress, cough, wheeze. There are what's called home management, emergency department management, and hospital management. In home management, immediate treatment with medication start with inhaled short-acting beta agonist as salbutamol. You can use even butadine or nebulizer up to 3 times per hour. If the child have an incomplete response to the inhaled treatment and persistent symptom or peak flow meter from 6 to 80% of predicted value, give short course of oral glucocorticoid therapy. Example, prednisolone 1 mg per kg per day for 4 to 5 days, in addition to the inhaled beta agonist. If the patient is deteriorating further, there are risk and have risk factor for asthma morbidity and mortality, so we give him emergency treatment or management. Sometimes patient come with emergency with severe dyspnea, tachypnea, silent chest, cyanosis, irritable, and this is sign of status asthmaticus. So status asthmaticus, child does not respond to routine measurements or treatment. In emergency department, we conduct of hypoxia, movement of airway obstruction, and prevent progression of symptoms. They are achieved by close monitoring with oxygen supplement, inhaled short-acting beta agonist up to 3 times per hour, nebulizer we can use, and systemic steroid, sometimes oral prednisolone 1 to 2 mg, or intravenous methylprednisolone, or sometimes even hydrocortisone vial can be used 10 mg per kg. We can add inhaled ipratropium bromide to these drugs. Patient indication of hospitalization. There are no improvement within 1 to 2 hours of treatment. If there are peak flow meter less than 70% of predicted, when oxygen saturation is below 90 to 92, where there are prolonged symptoms before emergency visit, and hospital management by oxygen, short-acting beta agonist, steroid, fluid. Rarely we need mechanical ventilation in case of impaired respiratory failures. Other therapy can be used in acute exacerbation here. IV theophylline, Heliox or helium oxygen mixture, and this will sometimes decrease airway resistance. IV magnesium as a trial of smooth muscle relaxant. What are the prognosis of asthma? Baby with recurrent cough and wheeze occur in 35% of preschool age children. Approximately 1/3 of them they have persistent asthma into later childhood. So 75% or 70% they will improve, and approximately 2/3 of them will improve their asthma. Asthma severity by the age of 7 to 10 years is predictive of asthma persistence in adulthood. So the baby has severe asthma in this age group, he may get to adult life. Children with moderate to severe asthma and with lower lung function, also they have risk for persistence for adult life. Children with mild asthma and normal lung function it's likely to improving with time. We need to educate the family of asthma. They should be taught how to use various spacer devices appropriately. It's important that they recognize the symptom of asthma and know how and when to seek help. Many children are given daily card to help them to recognize symptoms and also have asthma card which give them an individual treatment plan for acute attack. We give them a card and they record the attacks, how many attack, what medication they treat. This is help us in spreading of asthma. Other family education, take medications correctly, correct use of a nebulizer, understanding the difference between the quick relief medication and long-term medication, avoid triggers, monitor status asthma by peak flow meters, recognize sign of severe asthma, and seek medical help at proper time. Awareness of psychological factors as parent separation and child